All right. Well, I'll get started. So welcome everyone. I'm Beth Dolph with the Office of the Vice President for Health Sciences. And thank you for joining us for day one of our research speed dating week. We're excited to kick things off today with topics in aging. We'll begin with remarks from Dean Matosky-Wendy, and we're so grateful for both her time and her leadership. After that, we'll move into our 1 to 2 minute pitches. And following that, we'll have breakout rooms for continued conversation on the pitch ideas and topics. And we're glad you're here. We look forward to great discussion. And with that, I'll toss it over to Jill to introduce the dean.
Thanks, Beth. So we wanted to say thank you to Dean Matosky-Wendy again for taking the time to do this. She really, when we broke out the week over the course of different topics, she was really the ideal person to deliver the introduction to the topic of aging. And so we were excited that she had the time to do this and was willing. Many of you know that the dean is a very highly recognized, nationally recognized epidemiologist. She has been the lead of the Women's Health Initiative here at the University at Buffalo, I believe, since 1993. And that at a certain point, when the WHI was reconstructed to a certain element, she basically became the lead, and UB became the lead for the Northeast region. Some of you may not be aware, other than being the longest serving dean on campus. At one point, she actually established the Office of Research Advancement here at UB. So she understands the research space extremely well, not only from her own professional perspective and her own research accomplishments, but also from the administrative aspect of it and what it takes in order for people to be successful. With that said, before I hand it off to her, I did take a couple of minutes to dig a little bit into some data, and I don't know if the dean probably knows this far better than I do, but as far back as I have access to data on campus, she has had more than 27 major awards, totaling almost $42 million in research funding with her as the PI here at the University at Buffalo, which is a tremendous achievement. And so obviously that's one of the amazing reasons that she's dean and one of the reasons that she's here today, but happy to have her. And thank you, Dean, for being willing to lead this.
Thanks, Jill. I wonder where you get your data from. So Jill's all things data. So today I'm just going to do an overview of the Women's Health Initiative as one platform that we have, as Jill said, actually we wrote this contract in 1992, was awarded in 1993. At that point, I had joined the university in 1989, so was a very young assistant professor, and have used it to leverage other grants. And the original cohort of women was 50 to 79. I'm going to go through where we are today, but that cohort of women is now 80 to 107 years old. So it's moved from a menopausal cohort to one that's rapidly aging cohort. And I'm interested in kind of giving you a very, very brief overview, but maybe spur some ideas. We've had over 300 funded ancillary studies on top of the Women's Health Initiative, and I'm going to just quickly overview some of the resources in case any of you wanted to avail yourselves of that. And there are several people on today that I've known well and collaborated with, so anybody new, welcome. I'm just going to share my screen. Jill, is the right screen coming up?
Yes, it is.
You see my slide?
Yep, perfect.
Okay, let me just get in presentation mode. Okay, so thanks, Jill, for helping me kick off this matchmaking week and fitting for the first week in or the week of Valentine's Day. I'm going to go back in time. In 1993, we were awarded what was then going to be a 12-year study that included a series of clinical trials, large clinical trials, and an observational study to look at some of the major causes of morbidity and mortality in older women. Between 93 and 1998, we enrolled just short of 162,000 women in this study. So it's probably the largest study and certainly longest study of menopausal women that exists. There's a few other cohorts, the Million Women study in Europe, but this one was designed to look at major clinical trials that affected heart disease, cancer, osteoporosis, other chronic diseases in women. As Jill said, we were one of the initial vanguard studies, meaning the NIH enlisted 16 original centers. 24 were added 2 years later. We kind of developed a protocol, started the enrollment, then the others came on board after that. At the time, it was just after a report had been published on the status of women in the NIH, recognized there were few studies in women. This report ended up establishing the Office of Research on Women at the NIH. It brought in institutes, the NHLBI, National Cancer Institute, National Institute on Aging, and Musculoskeletal Institute all came together to help support this study. There was also the recognition that not enough was done in minority health. So the purple dots on our centers that were given extra resource to engage underrepresented minority women. And in the end, just short of 18% of the WHI are women who are of other than white race. Now, I said there were 3 clinical trials and an observational study. So of the 162,000 women, 27,000 were in a placebo-controlled set of trials on hormone therapy. About half of those were in women who had a uterus, another half women without, because you use different formulations. That is the trial that got a lot of interest. It's been in the interest again. They're reassessing hormone therapy in women at this point. None of our results have really ever been changed. It's more interpretation with a new administration, similar to the change in the food pyramid and change in vaccine schedules. We're now looking at women's hormone therapy, the risks and the benefits. There was a second study of dietary modification. At this time, it was to look at women who had a relatively high, about a third of their calories were fat calories, and tried to get them closer to 20%, as well as increase their fruits and vegetables and their fiber intake. And then a third study of 36,000 women put the women either on a placebo or a calcium plus vitamin D supplementation, 1,000 milligrams of calcium and 400 international units of vitamin D. And those were the trials. To date, the longest 10-year trial in postmenopausal women included 81 women. 27,000 is a big push from that. The study of dietary modification included almost 49,000 women. So this was a very, very large study, could only been done multi-center. And then anyone who was not interested in the trial or ineligible for the trials were put in a prospective observational study. And as I said earlier, cancer, heart disease, fracture were three of the major outcomes, but we study a number of different chronic diseases in these women. Now, the planning is in the salmon shade that started even before we were awarded. It took about 5 years to enroll all 161,000 women. And then the study was designed to go 12 years. But many of you have heard that the estrogen plus progestin trial stopped for more harm than good in 2002. And then the estrogen alone trial stopped in 2004. Really, the balance of risk and benefit was not, it was about one, a relative risk overall of about one, but there was an increase in stroke in that trial, and given the major benefit was on fracture, that trial was stopped prematurely as well. But the calcium D trial and the dietary trial went on as planned, and in 2004 and 5, we closed out that study. But there was interest in looking at the longer term effects, so a 5-year post-trial examination was funded at that time. Jill mentioned, the number of studies that were 40 centers across the United States. Eventually, in the mid 2000s, we changed from having all these sites to 4 regional centers. As she said, Buffalo became the hub of the regional center and took over the entire Northeast to follow up. And similarly, Wake Forest has center that covers the Southeast. Ohio State covers the Midwest, and Stanford covers the West Coast. And our coordinating center is at the Fred Hutch Cancer Institute in Seattle, Washington. So this follow-up that I talked about, a first extension study, took us through 2005 when the main 12-year study ended through 2010. But since that time, we've had a series of 5 and now, right now, a 7-year extension to continue to look at these women for the longer term results of the interventions that we did, but also to take on new studies looking at other aspects of aging that were not part of the original trial. I'm going to refer you to 2 articles. One, and they're both led by Joanne Manson, and both were in JAMA. One that was in just in 2024, and another previous 10 years prior to that, where kind of all the outcomes that were ever studied in the hormone trials were put into one large paper. Only Joanne could pull this off. There are lots of tables and figures, but if you want to look at some of those outcomes, I'll refer you to that. But there are over 3,000 primary papers from the investigators that are out in the literature if you wanted to look at those. But today I'm really just going to talk about the data that is available and potential opportunities for any of you who might be interested. There are tons and tons of questionnaires. At baseline, we did questionnaires on lifestyle, health history, family history, whether they were physically active, what they took in, their medication inventory, depression scales, functioning scales. We did measurements on height, weight, circumference of the waist. We did grip strength in the clinical trial. In 12,000 of the women, we did DEXA at baseline year 3, 6, and 9. And then from that point on, we did annual health outcomes, meaning we followed all the cardiovascular outcomes, any report of cancer, fracture, death and adjudicated. We got the medical records for those outcomes, adjudicated all those. And then there were a series of self-reported outcomes. For example, women just checked a box if they ever were diagnosed with Parkinson's disease or if they had glaucoma, for example. So we had a lot of self-report. And then we updated it annually for the past 33 years. We have sent them questionnaires that ask them about a variety of things. One of the years in 2017, we asked a whole series of oral health questions of all the women. And right now, in the past 3 years, we've been specific about issues on aging that we ask them about a number of different things like that. In all these women, when they enrolled, including the observational study women, everybody gave a blood sample, and we have stored blood samples. Over 5 million vials are stored at Fisher and McKesson. And we have a baseline sample on everyone. In the clinical trial women, we did a second sample a year into the trial. And then in observational study, we got blood out of everybody at year 3. There was a 6% subsample that got blood every 3 years in the study. So it was overweighted in the clinical trial, but 6% of the 160,000. In 2012, we did a long life study where we brought in 7,800 women and got a refresh blood sample. We did some height, weight measurements. We did some functional tests on those women, grip strength, balance test, walking test. This last year, we brought in 5,900 of those same women. And I should say those women in Long Life 1 and all were part of the hormone therapy trial. And so we have a number of things already measured in them. For example, we have done GWAS, Genome-Wide Study Association, in 45,000 women who were all in the clinical trial, and also all the women who were Black and Hispanic. And we've run CVD biomarkers, lipids, insulin, glucose. We also have measured in a number of the women vitamin D and many other things. So some of the markers are already run. And then we have, since the beginning, GWAS'd all their addresses and every place they've lived. And that data sits at the University of North Carolina. And it has been used, for example, to look at US air pollution and the outcomes in the women that we have. We also are fully connected to CMS. So as the women join Medicare, they become links. So in addition to everything we ask about, whether they've had a heart attack, stroke, cancer, and get that information, we have the linkage to CMS. So we had a group that were looking at knee replacements. We didn't collect that data, but CMS has that data. So, and that CMS linkage also has their medication inventory. We did a medication inventory at baseline. They brought everything they took, both in person, over the counter, and that was done again in year 1 and year 3. And then it closed out in 2005. We did another personal medication inventory, but you can connect to CMS. This is a slide I had made up in 2022, so it's 4 years old. But just to give you the number of outcomes, these are women, for example, that did not have breast cancer at baseline to join those studies. And you can see we have, since 1993, almost 12,000 invasive breast cancers that are incident cancers. Over 9,000 coronary heart disease, 4,000 women with heart failure, 7,600 incident strokes, colorectal, ovarian, hip fracture. We also have had about half of the women have passed away, but they also give us self-report. So there were 22,000 incident cases of diabetes that didn't exist at baseline, 60,000 women with incident hypertension, 18,000 with macular degeneration, and so on. So all these outcomes are available to use. And as I said, because of our connection with CMS, anybody who enters CMS, usually around the age of 65, all those events are also part of our database. As I said, we've been very productive. So in addition to the main WHI, there's been over 300 primarily NIH-funded ancillary studies. So we had studies that have looked at cognitive change in the clinical trials, the WHI memory study. We had a WHI eye exam study, the WISH and the WISE studies. We just completed a clinical trial where we randomized 50,000 of the women into a physical activity intervention. Half got an intervention, the other half continued their own way. But in Buffalo itself, we've had a series of studies that looked at oral health with our former colleague, Bob Jenko. We have had 18-year follow-ups of a cohort of women from Buffalo where we have saliva samples, blood samples, have done full mouth examinations and the like. As I said, over 3,000 published articles are out there, and there are about 3,000 papers in the works. We have over 1,200 different people that have published with us. So it's not just the 40 centers. I get calls from all over the country, and in fact, all over the world, of people that want to use this data set and want to connect with us. So it's been well used. I know in many of my PhD students or those from our Department of Epidemiology have used this data set in one form or another. So we are now funded until January 2028. We just created a document this month to share with NHLBI of all the progress we've made, hoping we could get another 5 or 10 years of study beyond the year 2028. I don't know that I'll be the PI for another 10 years beyond this, but certainly somebody will from our region. We are looking into an offspring study of the women who enrolled and looking for more and more ancillary studies from our own group in Buffalo. We have 3 different studies under review right now at the NIH. We're talking about doing another heart failure study. I saw Sue Sisto was on. We're doing a study in caregiving in these women, at least it's at the NIH right now. So we've been following these women for 30 years, and we have 30 years of their lifetime, 30 years of blood samples. We've also got this remarkable response rate. Our response rate it was well over 90% during the study. But we still maintain 80 to 90% response of the women who are still alive and participating. So our mean age is now about 85. Our oldest woman is 107 years old, and we have 42,000 women who are live, actively participating at these ages. As I said, we just completed and have papers under review for a pragmatic study to increase physical activity that included 50,000 of our women. But we've done other trials and studies. We have a large study called WHISPER that looked at sleep patterns in these women. We've added a new vision study. We've participated and enrolled 5,000 of our women into a cocoa extract multivitamin study. We're looking at all omics. So Heather Oakes-Balcom from UB, she's a genetic epidemiologist, has been now overseeing an omics study group from the proteome to the microbiome to the genome. In many ways, we can do this. We're doing cancer survivorship studies to look at the activity. We have a study now, 2 studies funded by the NIH that are looking at muscle mass and how muscle mass changes with aging. These are some of those larger studies that I talked about, and I can make these slides available if you want to read or look at them later. As I said, we're right now planning for our next questionnaire, which will be begun in February 2027. I'm on that committee, and we're looking at different aspects of aging, from vision to smell to hearing loss, the use of assisted devices, many questions that we ask, and we'll continue to get feedback from our women. We have full genome sequencing in about 12,000 of our women in a NIH-funded consortium called TopMed. We participate in virtually all the National Cancer Institute consortium studies, etc. This is just an issue of our public health magazine that we focused on our women, and these are actually Buffalo participants. If you're ever in Farber Hall, the buffalo that is at the entrance is the faces of these women. And this woman right here, Marion Abels, passed away, unfortunately, 2 years ago at the age of 107, but this was her at 104 on the cover of the Refresh magazine of the Buffalo News. And, we've got many, many resilient women like Marion that participate in this study. So that was a quick overview. And I want to point out that just if you go on the web, www.whi.org, there is an open website. There's data dictionaries, counts. You can find every publication ever been put out by a WHI investigator. All is there, who to contact. And obviously, if you're from Buffalo, you could contact me or some of our local investigators, Mike Lamont, Amy Millen, Heather Oakes-Balcom, are all part of our team. So I'll end my comments there, and we can open up for the next session.
Thank you, Dean. Can we ask if anybody has any quick questions for you before we launch into the quick pitches? Is that okay? All right. Does anybody have any questions for Dean Wachtowski-Wendy? The only other thing that I'll mention before Dr. Dolph runs into everybody's presentations is that I've been fortunate to sit through a couple of the dean's speaking engagements in the past. I always walk away from a layman's perspective, having learned something, and then sharing that information with friends and family. So what she's talking about is geared towards all of you as researchers, but the impact of what they do, it's as Pecori would say, it's like a dissemination, it's a success, because everything that they've learned and the talks that she gives are so impactful with the community that we're situated in. So thank you for everything that you've done.
Yeah, and I really want to acknowledge the women who joined that are just remarkable, but this is team science. So I'm an epidemiologist. I work with many clinicians with all sorts of subspecialties, and we have social scientists. There's lots of questionnaires that look at behavioral issues. And as I said, we're open to new studies that if you want to propose, I can work with you to help do that. Ben Chapman, who's on, is new to our university, about a year here, and his area is cognition and aging, and we're talking about ways we can use that. As I mentioned, Bob Jenko was a key person that added our dental component to it. And because of that, I had the pleasure of working with Keith Kirkwood, who also has been doing work with our team. So there's nothing I think we can't explore if any of you want to work, and it's fun to work in teams. I love team science, and I get to learn something from all of my collaborators every day.
Well, thank you. Dr. Dolph, would you like to start the speed sessions?
Sure. And we will kick it off. Dr. Chapman, you're first up on my list if you're ready to go.
Sure,
Thank
absolutely. Keep it to a minute. Ben Chapman, as Jean mentioned, new relatively to UB, was at U of R Med Center just down the thruway for many years, and at the NIA. My area, broadly speaking, is cognition in later life, and dementia, mild cognitive impairment, all aspects related to that. And specifically, I have an interest in cognitive reserve or resilience. So the dissociation we often see between objective measures of neuropathology in the brain and people's actual cognitive performance on test, how to measure that, what its determinants are, and particularly from a life course perspective. So looking back into midlife and even young adulthood and identifying factors that predict better cognitive phenotypes in later life. I'm also interested in resilience and functional status among people with some level of cognitive impairment. And also have a newer interest in the role or impact of medication on cognitive performance. I see some colleagues from Team Alice here, and that actually plays into the cognitive reserve and resilience area in a lot of different ways. So I'll stop there.
Thank you. And now we'll bounce it to Bob Waller.
Hi, thanks for having us here today. Dr. Ranjit Singh and myself are co-leads of Team Alice. If you don't know who Alice was, Alice Brennan was a woman who was exposed to an inappropriate medication, which triggered a series of events which led to her death 6 weeks later. We've taken that story and others in conjunction with her daughter, Mary Brennan Taylor, and developed Team Alice. Can I share?
Yes, you can.
Okay. This is what I want you to see. Hopefully you're seeing our project themes.
Not, oh, now we are. Okay, it just took a minute.
So, and I dropped this in the chat bot as well, but basically we are on the left-hand side here, we look at what is an inappropriate medication use, and as Ben alluded to, and we're interested in the WHI data set as well, is how do medications affect the problems such as functional decline, cognitive decline. We're looking at both physical injuries such as falls, as well as cognitive impairment, which puts older individuals into nursing homes and situations that they may not want to be in. We're also looking at how that impacts their caregivers. So that's kind of characterizing the problem of inappropriate medication. And then our themes 2A and 2B focus on what can we do about them, interventions to address inappropriate use, and then testing these interventions. Our other aims are training and aging research. We have a series or a group of trainees from various schools where we're developing them in the area of aging research. And then our fourth theme is health professionals education, both while they're in their schooling as well as postgraduate. What can we do to get the message out about inappropriate medication, deprescribing, and overall safety in the use of medication in older patients? I think that's been less than a minute, so I'll stop sharing.
Thank you. Next on my list, I have Sandra Coleman.
Thank you for organizing this. I'm going to try to quickly share a slide. So I do not study human. I am basic researcher studying mice, and we are interested in the neuroscience and neurophysiology of how neuron activity can lead to changes in behavior. And most recently, we are interested in cognitive flexibility, and we designed a new device that allows us to test cognitive flexibility in mice. And so I'm seeking collaborators that might have insights into mouse models of cognitive decline associated with cognitive flexibility deficits, or people that are developing new treatment strategies to be tested in mice. And I guess a pet idea that we also have is for individuals that have extremely good cognitive flexibility, might that help with resilience? And so we look at these things at two levels, the behavior and then the neural dynamics, by actually accessing the neural activity of individual neurons using electrophysiology or imaging techniques. Thank you.
That was a very tight minute. Thank you. Let's see. I believe Sue Ann Sisto, are you on?
Yes,
Can't see
I
my
am.
people. Great, thank you.
I don't have a slide at all, but just an idea. So we have a grant under review, but we're really interested in aging and caregiving in rural communities. And so trying to provide transition materials for people who are transitioning from acute care to rehab. I guess I should say I'm the chair of the Department of Rehabilitation Science in the School of Public Health and Health Professions in Jean's department. And so our focus is really looking at the use of AI and really trying to generate very specific content for people in rural communities who are transitioning from the hospital to acute care setting to rehab and eventually home, or many times they have to skip some of those steps. So we're looking for collaborators who know a little bit more about AI and the use of generative AI and delivering materials that could be useful for caregivers of people with brain injury, stroke, concussion, and also those who are simply just aging in place. So that's my story, and I'll stop there.
Great, thank you. I believe that's everyone who I had signed up. Is there anyone else who wants to jump in and do a pitch?
Hi, jumping on in very much in a jump, but my name is Doug Buzak. I'm the Associate Director of Advancement in the School of Public Health and Health Professions. And I work with Sue Ann and Jean many times, to kind of support your work from the funding point of view, where I come across many individual donors and alumni. Sometimes our alumni are other, um, experts in academia, looking for collaborators at UB. And sometimes it's me working with other corporations or foundations to further support some of these areas in aging and or caregiving as an extension of it. So if anybody ever needs my thoughts or connections, I'd be happy to talk with anyone, because this is definitely an area that I find in conversation with many of these folks from corporations, foundations, and individuals. So if I could be of help to anyone, please reach out anytime. Thank you.
I would just add a caution to that, that he's supportive of the School of Public Health and Health Professions. So if you're sitting down at the Jacob School right now, I would not pick up the phone and call him and let him focus on the growth in public health. But if you need connections with any of the other advancement colleagues in your specific school, put something in the chat and I can help with that. Sorry,
Yeah,
did I overstep saying
no,
that, Dean?
it's very collaborative, and yes, sometimes Jill or myself can always point anyone in the right direction, because there is sometimes a little point in the right direction. But we're all trying to collaborate, and there's a lot of great collaboration between schools and departments and units within health sciences, even sometimes outside of health sciences, where a lot of sometimes that AI work or with certain devices extend into the School of Engineering, perhaps. So, we can both help, in any way.
So logistically speaking, I'll jump in as I'm cruise director for Dr. Dulf on this stuff. We have 3 breakout rooms, and so they're actually open for anybody to jump in and out of as you so choose. We try to keep them simple because we're going to be running these all week, and selected topics as related to potential basic science opportunities, anything related to clinical efforts, and then also programmatic or community facing type work. So if you'd like to, please feel free to come and go. I do, as you're going through the breakout rooms, I do have a poll that if you could complete it before you leave our session today, that would be great, because what we would like to do is help facilitate any sort of follow-up. If you make a connection, and I see that there are some things going back and forth in the chat, if you make a connection, feel free to reach out to us, and we'll start connecting people for follow-up sessions, because I realize that with 14 minutes remaining, that's not a lot of time, but we can at least support you and get things going. And last thing, if anybody's jumping off before the conclusion, thank you to Dr. Dahl for organizing our speed dating for the entire week. And
if anyone needs to know, if anyone's unfamiliar with the breakouts, on your bottom Zoom toolbar where it says more, if you click on the 3 dots and go up to join breakout room, you'll be able to join from there.
Well, thank you to everybody for jumping back. Our team is learning all about all of the breakout room and the polling stuff, and it was kind of fun to watch it in the background. So wanted to thank all of you for your participation today, the Dean especially for such a great way to kick off our week and such a wonderful session. And then thank you again to Dr. Dahl for organizing all of this. And we're going to give this a go. We've read in the literature that this is really successful at other institutions. So as a result, you have the poll up in front of you. If you have a minute to take it and give us some feedback, that would be wonderful. And then we were happy to help support any follow-up meetings moving forward if you had some topics. But did anybody want to make a comment before we wrap up? Happy to have you chime in.
Jill, I'm just saying I don't have a poll in front of me right now. So just I don't know if others do, but I'm not seeing a poll.
If you go to the 3 dots below on the bottom.
Oh, okay.
And then hit polls and what is it?
Polls/quizzes.
Polls and quizzes. Yeah, mine's gone because I finished it, but yeah.
Okay, thank you.
Thank you, Jill.
All right, thanks to each of you. Good to see you. Stay warm.